and Indo-US Super Specialty Hospitals, Hyderabad, India, and Dr. Anuj Kapadia, who would moderate the program. Dr. Prakash Kumar Hazra from Kolkata, Dr. Katharina from Austria, Dr. Puneet Verma from Mohali, Dr. Gomez-Hospital from Barcelona, Dr. Manik Chopra from Ahmedabad, speak on various topics. And it's our pleasure to have Dr. Sirish Hiramat, who is Director Cardiac Cath Laboratory, Ruby Hall from Pune, as the chairperson of this evening. So we begin the program by introducing the chairperson, Dr. Hiramat, and then the program would be all sirs. Sir would take charge of the proceedings of the webinar. I take this pleasure and it's our honor to introduce Dr. Sirish Hiramat to the faculty as well as the delegates and the audience of today's program. Dr. Sirish Hiramat is a revered teacher and an astute clinician. Sir has held many positions at the national level as a president of CSI in the year 2017. Sir has handled the CSI conference in 2016 as the program chair. Sir was convener for the National Interventional Council of India, CSI, from 2004 to 2006. Sir has performed various live angioplasty courses, and those have been telecasted to various national and international conferences. Sir has also proctored many interventional cardiologists and has given live courses across the globe. Sir has great experience in peripheral angioplasty, including legs, iliac, and carotids. Dr. Sirish Hiramat has participated in some groundbreaking trials. Sir, it's our honor and privilege to have you this evening as the chairperson of the program. It would be a wonderful experience for all of us to learn from your experience. Now, the program is all yours, sir. Request you to introduce the moderators of this evening and then take the program forward, sir. Thank you.
Yeah, good evening, everybody, and thank you for that introduction. I hope you're able to hear me clearly.
You're audible, sir.
Okay.
Thank you.
So in 2021, we are talking of valves again. I think an area which was very, very surgical for years together. I remember our story when I was doing my post-graduation, just medical treatment and surgery in India too was growing at that stage. However, we have a big hospital, which was a state referral hospital for valve surgery. And in Pune especially, we had a very, very big number of valve surgery going on. So this was like a national referral center. And even the Army Institute was doing lots of valve work. Overall, the valve affection has clearly changed in the last 40 years or so. And from rheumatic, which needed intervention in early days, 30 years back, it's now elderly valves which are degenerated and requiring attention. So if you see the regular annual meetings that the Cardiological Society holds, I think valves are again becoming important, but coming via a different route. These are elderly valves, aortic stenosis, and so on. So we have a very interesting program lined up today for you all. And Ravi, we could start with the
Sir, Hiramat sir, request you to unmute, sir. Yes, sir.
I said a few things. You heard it or you
Yeah,
didn't?
you are audible. You are audible, sir. You are audible.
So let's get into the first presentation.
Yes, sir. So I would flash the profiles of the moderators, request you to kindly introduce them, and then we take it over, sir.
So it's always an excitement to have somebody as knowledgeable as Dr. Sharat Chandra. Many of you know that he was a president of CSI in 2018. So he was 1 year after my presidentship. But he has been on the national and international scene prolifically, all the time, giving different kind of presentations. So he will be able to help us today whenever things are going wrong, or a very valued opinion, as I would think that would be. So currently he's in the Virinchi Hospital, an Indo-US super specialty hospital in Hyderabad as a consultant cardiologist. There are lots and lots of students he has proctored, got training under him, and I'm sure they are in various parts of the country doing very well. The second help would come from Dr. Anuj Kapadia. He also hails from Hyderabad, the AIG hospital from Hyderabad. And again, deep interest in all kind of cath lab procedures. I think the Indian cardiologists are clearly more exposed to balloon mitrals, one area which is so very typical for the Indian cardiologist. So we have Anuj and Dr. Sharat Chandra as moderators. And Dr. Ravi, let's get
Yes, sir. So we have the first speaker, Dr. K Hazra. Request you to introduce him to the audience, and then sir would take us through his presentation.
Dr. Hazra is immensely experienced, and what I like about him is he has a thinking which is not always like a mass thinking. He always has something special up his sleeve, and that's why in various groups where he and I are together, he's a very controversial cardiologist. But that's an excitement. He's thinking the other way around also, thinking for the benefit of the patient. And all new techniques he likes to acquire. And that's why he and his team are one of the leaders across the country. So indeed a pleasure to have you, Dr. Hazra, today. And you could start your presentation.
Thank you, sir. Can I share my screen?
Yes, sir.
Yeah. So
I mean,
can you see my screen now?
Yes, it's visible, sir.
Okay. So today's talk is nothing new. I need Verma, Dr. Sharat Chandra, Puneet, myself, Dr. Cases of structural heart disease. The main constraint of TAVR or TMVR in our zone is the financial constraint and maybe a smaller size of the arteries, small pocket, small arteries. So minimally invasive procedure to replace heart valves is superior to open heart surgery for patients with intermediate risk of complications. And this field is ever increasing with the advent of newer techniques, newer valves, smaller sheaths, much more forgiving device, and the prices are also coming down. So there are more and more trial, and the spectrum of non-doable cases by surgery are extending to much doable surgical cases, and we can put this TAVR or TMVR even in equal footing, even in equal situation, where the surgeons also can do a good job. And we are competing with a surgeon who has got a tremendous experience in the field of mitral valve replacement, aortic valve replacement, tricuspid valve repair for pretty long time. And we have just entered into the field. So gold standard is definitely surgery, but there is always a silver lining in our TAVR or non-knifeless or non-cutting technology. So despite AVR being a class 1 recommendations for severe asymptomatic aortic stenosis, more than 1/3 of these patients are unable to undergo AVR because of comorbidities like porcinal aorta, COPD, renal failure, and other comorbidities. Or the patient who had a previous surgery and addition of the sternum because of the previous surgery. Many times we do manage these patients medically, taking care of their hypertension, cholesterol, anemia, iron deficiency, diabetes, atrial fibrillations, and other precipitating factors. And sometimes they do well. But when there is an option of living longer with a new therapy, which can be done under local anesthesia, and once you share this decision with the patient and the relative, many of these people, they do agree for transcutaneous valve replacement therapy. So this knowledge, which actually originated much before Dr. Crivier in a pig, which was almost 7 years before Dr. Ellen Crivier, but that did not see the light of the day because this man did not have that kind of fund, and he did not publish his study in the leading journal like NEJM or Lancet. So Alan Crivier, he took the lead, and what we have learned today as the TAVR is concerned, just because of him, and he's the first man to do such. The spectrum of disease, managing aortic stenosis with small air, aortic stenosis with mitral stenosis combining TAVR, or restenosis after a biprosthetic valve, TAVR or TMVR, the valve which is leaking on the left side by clipping, by Pascal or mitral clip on the tricuspid valve. We have a Pascal and we have mitral clip on the tricuspid valve. Pulmonary valve can be replaced percutaneously. So this knowledge and spectrum is ever increasing, and more people are venturing, the younger cardiologists, and we are also learning a technique from our masters. Because we can perform this with much easier because of smaller size of the sheath, better understanding of the anatomy by CT scan, mandatory CT scan, CT angio, and other imaging facilities. And we know that this surgical thing can produce strokes, and these strokes are quite debilitating sometimes, and they live with the strokes throughout their life. We can also produce same kind of strokes and MRI hits in the brain, but those can be prevented by filters. So ultimately, this is one spectrum where many things can be done percutaneously, whether it's pulmonary valve, valve in valve, valve in valve in valve, or an artificial heart having aortic regurgitations, aortic stenosis, bicuspid valve, pure air, only one type of TAVR is indicated. And now we are venturing on the right side of the heart. And many of these people are actually having very severe heart failure. And maybe the comorbidity is much more prevalent in this group of people who has got severe TR. Many of these patients, they do have a pacemaker inside. Now in India, we had 10 million patients above the age of 80 years. These octogenarians are more prone for multivalvular disease, coronary artery disease. Now we can tackle this calcium of aortic valve, though in future it can be done by a percutaneous ultrasonic lithotripsy-like thing, aortic stenosis. Few cases has been presented in PCR, around 30 cases by transcutaneous lithotripsy, just like intracoronary lithotripsy, and have produced a big, good outcome, long-term, and 6 months outcome data has been presented. So current population of 130 crore billion people. Imagine the number of people ever increasing. Now we have three types of people in the society. Those society who has a population of more than 7% above 65 years, they are actually aging society. 14%, they are super aged society. If it is 21%, they are actually having only elderly people. So these countries are Italy, Japan, South Korea. Singapore will enter in 2030. US will enter the super aged society by WHO criteria by 2050. India will take some time to reach the super aged society, having more than 14% population above 65 years. So these people do have multiple heart disease, and one of them may be aortic stenosis. So this population size actually lead us to the opportunities to understand, to propagate the idea of having TAVR easier way with less morbidity, less stroke, and less pacemaker, less scar on your body. Now in this field, 2011, 80-year-old female patient with severe AS, that was the beginning with Medtronic core valve. This is non-recapturable, but now we have many recapturable valve. So transcatheter valve technology has evolved over time. However, a lot of standardizations, upgradation of skill, heart team approach need to be formed up in the country. And there are many people who are actually helping to propagate the science. So they have seen one, they have done one, and they have taught one to us like juniors, and perhaps they will be doing one on their relatives. That's how the science progresses. So see one, do one, teach one, and do one on your mother, on your father, on your brother. So it should be so passionate. Now we are actually moving into that field. So there are different numbers available. Which city has got the maximum number? Maybe the North India, Delhi, and in Calcutta, the numbers are small. And there are a lot of hurdles to be crossed before you convince somebody. They actually cross the boundaries of the state to other state, like Southern India, Northern India from Eastern India, because of they have started everything for the first time, and we are lagging behind. So maybe the Bangladesh moving to Kolkata moving to Bombay or India, Delhi or South India. So this migration is possible, and this is quite realistic, and this is quite understandable because the technology team and the infrastructure, the expertise is available, and there is a spectrum of people who are more trained and more special kind of structural heart disease specialists. So there are a lot of heterogeneity in the standardizations, the techniques, the experience, but I'm sure with time, with this kind of seminar, there will be homogeneity in the field of, so every center cannot have equal outcome data, but I'm sure with time, they will be almost nearer to the ideal one. So the market is ever expanding, aortic valve, mitral valve, pulmonary valve, and last in the brigade, we have tricuspid valve. So tricuspid valve is a unique disease, and this tricuspid valve market can be extended because many of these people, they do suffer from the comorbidities and the effect of tricuspid valve on your systemic venous system in form of ascites, leg edema, recurrent heart failure, tiredness, raised enzymes, and so on and so forth. So in this field, major players of TAVR market like Medtronic, Boston, Edwards, Mary Lifeson, St. Jude Medical, JenaValve, and some people are still fighting for their space because the price issue, like Edward, the number is very good, Merrill number is very good, but other companies are struggling because lack of data and confidence amongst the implanter. So the future market is, as I said, is very, very encouraging for the industry point of view. From the doctor's point of view, for the juniors, those who are listening, I think this future, they can be expert, they can be like legends, like Dr. Hiramat. They are the legends in the coronary field because they had the advantage of time, because the angioplasty, the stent, etc. came in their time. So time has come to understand the basic multivalvular heart disease, to know, to see, to do, and to spread the knowledge of this kind of therapy to most of the Indian eligible patients. Do not do harm. So your treatment should never be worse than the disease itself. But tricuspid regurgitation is one area where you can do harm than the pre-exist. I mean, the treatment can be more injurious, more harmful to the patients than the disease itself, until unless you selectively you select your patient according to the guideline, CT idea, CT scan, etc. So tricuspid regurgitation, the incidence is very high. And if you do a systemic echocardiography in almost all patients who has visited your hospital with hypertensions, those who have hypothyroidism, those who have COPDs, those who have had a previous heart failure, PH, left-sided heart failure. The left-sided heart failure is the commonest cause of right-sided heart failure, tricuspid regurgitations. And once you have a complete heart block kind of thing, you have something indwelling catheters, like in eastern part of India, the pacemaker is very high, very, very high. And you'll be surprised that many of these patients are having complete heart block. They have 2, 3, 4, 5 leads. They have ICDs. So these things can precipitate their tricuspid regurgitations. The tricuspid regurgitation, again, volume dependent, preload dependent, that dependent on the therapy they are getting, diuretic dependent. So sometimes it's very difficult to assess them. But if you are happy that these patients' TR remains same or it progresses in the form of advanced right heart failure, ascites, edema, hepatomegaly, they need something to be done, and which is possible nowadays, putting 2 stents, 2 valves, one in the SVC, one in the hepatic vein, in the IVC. So there is a recent data that tricuspid valve surgery has improved also over time, repair, that Pascal system, that mitral clip, as I mentioned. But these are again Pascal, and Pascal is not available in our country. Mitral valve surgery is again 40 lakhs, 50 lakhs. Only few centers are doing, mainly on the left side. For the right side, I do not know any center has done so far a mitral clip-like thing in the tricuspid valve. Again, understanding the tricuspid valve for a clipping is much more difficult, much more problematic than you do on the left side. So much more knowledge is available on left side, but right side here, the clipping is not that easy. And primary and secondary, everybody knows in this August gathering, dilatation of the annulus, remodeling of the RV, RA. Now, putting a valve in the right side was definitely problematic. If you have a lead, you have to explant the lead, then you go for a pacemaker. If you have put one valve, there is always a chance of valve thrombosis because the low pressure in the RA. So there has to be some flow through the valve. And you know, this valve is very big, the annulus is very big. You can get isolated atrial fibrillation later on. You can get PH later on. So there are different spectrums of regurgitations, functional and organic. And the surgeons, they know better than cardiologists how to deal with this. But I'm sure today's seminar will enlighten us further on how to assess. So with that note, I would like to thank for her kind attentions, and I will hand over the sessions. So this tricuspid regurgitation does need new approach to treat them, identify them demographically by age and sex, clinical symptom, comorbidities, cardiac disease, surgical characteristics, their PA pressures, right heart study, their saturation, their left to right shunts, the PO4 can open up, the LV pressures, the intra-arterial volume, intra-arterial pressure, all need to be understood before contemplating this tricuspid valve therapy in terms of putting 2 stents. And these are permanent devices, cannot be removed. We have now more stents available in the intra-arterial septum, which can deal with right to left shunt, left to right shunt in HEPPEP and in HEPREP. So this field is again very, very encouraging. And in this field, we have many devices. And these are again very, very innovative and very, very elegant, smaller in size. The seat size has come down. The device is much more forgiving than what it was previously. So with that note, tricuspid valve can no longer be forgotten, and the tricuspid regurgitation need to be treated to improve the overall quality of life of the patient, as severe tricuspid regurgitation has significant impact on survival. various interventional devices available for the treatment of tricuspid regurgitations. However, superiority of one device over the other yet to be established. K valve implantation system seems by far a good choice for the treatment of TR, and considering the dynamic nature and the complexity of the tricuspid valve apparatus, one has to go through the training and see few cases before you attempt implanting this valve. Now, one of the component can be implanted for superior vena cava type of ASD. We have few cases in India, but in most of the cases, it has to be SVC and IVC, and this is quite possible. And this is quite attractive solutions for many of these patients. And before sending them for surgery, please think of this kind of therapy, bicaval valve implantation. Thank you very much.
Thank you, Dr. Hazra, for that introductory talk. I think we are all in business for the valves now. It's always nice to have Dr. Hazra to open. It's like sending Sunil Gavaskar, and you're quite sure that the meeting would be very steady right through. So Dr. Hazra actually highlighted the Indian component, and we all know that rheumatic heart disease has been very prevalent in India. In fact, heart surgery in 60s was mostly limited to valve surgery, and these were all rheumatic valves. So their age group was something like 30 or 25 and so on. So these are the ones who would come for a repeat procedure 20 years later. So they, at that stage, they're only about 45 or 50 years. So any innovation in valves is going to be extremely useful for India, where rheumatic was very, very prevalent. Fortunately, I think overall these efforts by CSI and individual doctors have taken hold of the rheumatic valves. I remember Dr. Alan Cribier coming to India many times to perfect his techniques and modify his mitral techniques in early part of the century. So we are now actually tricuspid valve is one thing which I think surgeons also never like to replace. I mean, if you see, most of the surgeries would have mitral plus aortic replacement, and tricuspid is always repaired. So I'm sure the surgeons probably had a distinct feeling that we should not replace the tricuspid valve as far as possible. So today, when we think of tricuspid valve, most of the time they have a valve repaired or replaced on the left side. And now we are handling the tricuspid valve. So just for tricuspid valve, a repeat surgery, open heart surgery, is probably too much to pay for. And that's why the interest in percutaneous tricuspid valve is growing. Thank you, Dr. Hazra, for the introduction. We will have a discussion all towards the end. Dr. Ravi, can we have the next talk?
Yes, sir. We have Dr. Katharina as the next speaker.
So good evening, Dr. Katharina. We are moving towards dinner time in India. So it's indeed nice. I mean, Vienna is one city where I always love to come. So if there is a conference, I never miss out on Vienna meetings. I think your CV is outstanding, and working in this field for so many years must be a great experience. However, you're also talking to an audience like rheumatic heart is very common in India. And when we appeared for our cardiology finishing examinations, I think 80% of the viva used to be on rheumatic valves. So it is exciting because auscultation is important, arrhythmias are important, and which valve to address, these kind of decisions are also important. And more importantly, when to address. Like if you imagine a lifespan, somebody who is very sick at the end of second decade, age 20, and you have to carry him to an age 80 at least, I think you have to have a proper thinking, which are the ways in which we can take this gentleman to an age 80. So on this background, I guess any advance in the valve preservation or a valve which can go on for a longer time and can be replaced easily is going to be a big excitement. On this front, my Indian colleagues would be very excited to hear from you, Dr. Katharina, your experiences in the valve preparations. Over to you, Dr. Katharina.
Thank you very much. Thank you very much for the very kind introduction. I have to say, I also enjoy coming to India a lot, and it's a real pity that COVID is now hindering this personal presence, which I would enjoy very much. So it's a great pleasure for me and a great honor to take part in this webinar. And I was asked today to talk a little bit about complex cases. And I would like, just as a beginning, to share some few slides that I think the members of this webinar are already familiar with. As I was already introduced, I'm a cardiologist from my background, and I'm also CEO of Products and Features. So we have already heard very clearly about the background of tricuspid regurgitation, and I think it is really super important what my previous speaker, Dr. Hazra, had said, but also you, Dr. Hirmas, because many of the cases we are facing now are cases that have been treated or patients that have been treated for other valve diseases early in their life or who have received pacemakers. And it is very important to remember that tricuspid regurgitation is actually not a disease of the valve itself, but it is a disease of the right ventricle. And this, I think, is very important when we discuss the different concepts that there are for tricuspid regurgitation. We are talking about a dilatation of the annulus with an increased coaptation of the leaflets and an increased tethering. So why is it important? I think this has also been mentioned, and I only want to show one slide today. We know that the presence of severe tricuspid regurgitation impacts prognosis significantly. And we know that if left untreated, severe TR is associated with a very high one-year mortality, as high as 35 to 52%. And this is also true in cases where we treat the mitral valve, where we treat the aortic valve, or where we have other comorbidities. So it is not trivial if the tricuspid valve is severely regurgitant. And we know that patients with long-standing TR often develop signs of right heart failure, and as already mentioned, ascites, peripheral edema, weight gain, and hepatic and renal dysfunction. I think it is very important, and it's been stressed before, that in the combination of left-sided valve disease and tricuspid regurgitation also impacts mortality significantly. And in the presence of TR, heart failure and AFib are dramatically increased. So if we just talk about the spectrum that we are having, and I think this is a very important slide, it shows that in secondary TR, and this is what we are mainly addressing, not only, but mainly, we can talk about phase 1, which is mild tricuspid annulus dilatation. Here we still have a place for probably annuloplasty devices or probably clipping devices, more so in phase 2, where we have moderate tricuspid annulus dilatation and in initiation of tethering of the leaflets. We can use coaptation devices. We might want to use a combination of both. And of course, we will start to evaluate the role of new devices that might have a direct replacement of the tricuspid valve. At the moment, if we talk about phase 3, and this is severe tricuspid annulus dilatation with tethering of the leaflets, large coaptation, in the presence of a preserved mild to moderate right ventricular function, I think TricValve at the moment, the BCAVAL implantation is the only technology with a lot of experience in the market. So I will want to elucidate further on this. And I think the slide that was shown before about getting the right point of treatment, the time of treatment is crucial, because at the moment, of course, many of the patients are in a very late stage of their disease, and they might have passed the point of no return already. So I think the next month and years will be to find out exactly where we need to treat and when we need to treat. So I would just like to introduce the system shortly for those who have not attended the previous webinars. This is just a short video showing the principle of the BCAVAL valve implantation. As we are aware, in the course of disease, the tricuspid annulus is dilating. The valve the leaflets will not coapt any longer, so our coaptation becomes wider, as we can nicely see in this illustration. And the BCAVAL valve implantation, the TricValve, is a principle of putting 2 biological self-expandable valves in the superior vena cava and inferior. So they will be delivered by 2 dedicated devices, and they will then block the backflow into the cavas, thus reducing congestion and reducing symptoms. This is how the valves look like, and I think for the next slides I want to go through, it's very important to keep this in mind. Those are 2 dedicated valves. We have one valve, which I always call the one with the crown and the belly. This is the one for the superior vena cava, whereas we have the double funnel concept with a short skirt, and this is the valve dedicated for the inferior vena cava. It's important that both valves are self-expandable in their nature. They are nitinol, and they come with bovine pericardium. And here also only dry pericardium is used. I think, in my opinion, that's the way to go, because you want to take the devices off the shelf. You just rehydrate them for 3 minutes, and then they're ready to use. The dry pericardium has undergone extensive testing. And what we can show in the testing is that these are the images from the 200 million cycles that, of course, all the valves undergo during their preclinical testing. And I think it's very important to see that even after 200 million cycles, the pericardium is still in perfect shape. We have an anti-calcification treatment. It's free of any preservation solution. So you're free of the glutaldehyde that normally comes with the valve. We could prove that we have a higher durability, and of course the handling is much easier and faster. So I was asked today to present some cases with a complex anatomy, just to point out some pitfalls that you might encounter during your implantation process. And this is a very nice case from Spain. Typical background, patient not too old, but as already mentioned, mitral and aortic prosthesis, as well as tricuspid annuloplasty in 1995, AFib, and severe tricuspid regurgitation. I think it's here, if we look at the CT scan, and this is why it's so important to have a good quality CT scan for the evaluation of the technology. If we look at this CT scan, we can appreciate that we have a very short superior vena cava. So of course, and we have a tapered part here of the superior vena cava when it in the transition to the right atrium. This is a very familiar picture, so it will occur in a lot of patients, especially with long-standing disease. And of course, you would risk possible migration or embolization if you'd place your valve here. So what is the solution? I show you some of the implantation videos because I think it's always good to see. Here we have the catheter in the pulmonary artery, which serves as a landmark. In this patient, we use the TEE, although this is not mandatory. Patients can be done in sedation without ventilation. And we see the confluence here of the brachiocephalica. So what was done then in the next round, the crown of the valve that usually would be around here was placed high up in the jugular vein in order to give it a good landing zone. And when the valve was deployed, we can see that we can, due to the self-expanding nature, it's expanding in a nice way. And here you can see that the lower part is fully expanded with the valve-bearing segment facing the right atrium. So we positioned the valve a little bit higher in the jugular vein with good attachment, and therefore we could reach full sealing in the superior vena cava. So it is very important to keep the CT scan really in mind. This is another case from Spain. Spain was our main country for our CE trial, which has been finalized. Enrollment is finalized, and we expect CE mark within the next 2 to 4 weeks. So all hurdles have been passed. This is another very good case where we had a CT scan with very good contrast in the superior vena cava and the huge right atrium. But what you could see is that there is lack of contrast in the inferior vena cava. So we were further investigating on this case, and we could see that there is a large Eustachian valve and obviously quite an angulation of the inferior vena cava. So we decided to move ahead. This is first an angiography of the superior vena cava, where also here we have quite a short distance from the bifurcation, from the confluence to the right atrium. And when we further looked at the IVC, you could see that there's a very tortuous anatomy, very unusual in the cavas. You can see that the patient had a pacemaker in place. Although this is no contraindication for the placement of TricValve. So the echo was done showing torrentious TR. And here we can see that first, and I think this is interesting because the question arises quite often, what happens with the pacemaker leads? And here we can see that during the deployment of the valve, the pacemaker lead is just sealed between the vessel wall and the stent frame, and there is no tension on the pacemaker lead. Ideally, of course, you try to avoid wrapping the pacemaker around the valve, but even this is not a problem at all if you deploy the valve safely. So here we can see what we did with the inferior vena cava valve. We still had a catheter in the infrahepatic veins to visualize the inflow. We tried to place the valve as level as possible. And then it's important with the technology that you have a very slow deployment. So what you can see here is that you still see the angulation, but you could see how careful the valve was released in order to allow full deployment of the stent frame. So by this, you had no jumping and the valve was deployed in a very stable way. It's also important to remember that you can retrieve and resheath the valve up to 80% of the deployment. So even if you're not satisfied with your position, you can still retrieve it. So we reached a very nice final results with the 2 valves in situ. You can see the pacemaker here without any problem. One nice case, because we are now also initiating our clinical trial in the US, as we have been granted the FDA breakthrough device designation. And the Cleveland Clinic is actually our PI, and they are just going now for one arm that will only include patients with failed prior technologies such as cardioband or clipping. And I think this will be very interesting to see. So this was a patient that in 2019 had received the cardioband, but had no significant change of the diameter or the tricuspid regurgitation. So we decided to treat the patient. The anatomy was very favorable for TricValve implantation with a nice and straight superior vena cava and a straight inferior vena cava. This is what you would like to see. So here we can see the cardio band, we can see the prior valve prosthesis on the left side, and you can see that without any problem, the SVC valve is already placed, and then the IVC valve is placed in the next step. And you can see here very easy deployment. Here we have one guide wire in the right atrium in order to outline the dimensions, which is another trick or another length help that you could apply. This was the final result. So again, very nice result. You have the different devices here, and you have the TricValve safely deployed without any issue. And I think this is very important, because what you mentioned upfront, Dr. Hermas, is that, of course, we don't want to harm the patient. We want to have a technology that is safe and that we can look to improve the patient, but not to do any harm. So in conclusion to this part, TricValve can be deployed very safely in a large variety of challenging anatomies. Pacemaker leads are no contraindication. And in case of a short SVC, it's important to remember that you can place the valve higher. And it's always important to place the IVC valve as low as possible. And this is why CT scanning is so important. With a good CT scan, you have already done half of your procedure. And I think this is why we always insist on a good quality CT scan. And I was asked today to give a short outlook also on future pipeline that we will bring to the market together with Relisys for India. And we are all aware that transcatheter mitral valve replacement is, of course, a very important topic. Still there, our surgical colleagues are doing very well. So we have to be really good in order to be a competition. And this is the first time actually that this is shown. This is the transcatheter mitral valve. It's a self-expandable valve. It's 3-leaflet. It's fully transcatheter, transseptal, and it also comes with dry pericardium. Here is a sketch of how it is implanted, and we are doing the first in man within the next 4 to 6 weeks. We are slowed down a little bit. We are slowed down a little bit by the COVID situation, but nevertheless, we are very confident that this will take place very soon. A second, that this is our most exciting development, is the so-called aortosafe. It's a minimal invasive transcatheter endoventral procedure. So here the target is to treat patients with type A dissection, either for bridging, but more ideally, of course, for complete curative approach. So this is only possible because you have 3 components. The 3 components consist of 2 covered graft stents that will secure the entrance of the coronaries. And then you have the dry pericardium, which allows you to have the full device fully assembled. So we have the aortic valve with a dry pericardium and the graft stent. And you have the opening for the coronaries in a rotary principle. And these were the prototype test results. And here also the first in man is planned within the next few weeks. So I think we have a lot of, a long way to go, very exciting way to go. And looking very much forward to these new developments and hope we will all be part of it. Thank you very much.
Thank you, Dr. Katharina. I think we'll take the questions all together in the end, because some of the questions may get answered in the next presentation. So we go to the next presentation.
Yes, sir. So we have Dr. Puneet Verma, who will be sharing his experience. His profile is displayed on the screen, sir.
Hi, Dr. Puneet, floor is yours. So you're muted, Dr. Puneet. You need to unmute yourself.
Thank you, Dr. Hiramat, Dr. Sarath, distinguished faculty, Dr. Katharina Kiss, and others. It's a pleasure to be a part of this important symposium. The task entrusted to me is to present my maiden experience with the TricValve, and I present this case before you. This is a story of a 70-year-old lady who's a bronchial asthmatic, hypertensive, long history, a CMV closed mitral valvotomy in 1978. 20 years later, she underwent a Star Edwards mitral valve implantation. Did well for reasonable time before in July 2009, she had a stroke, but there's no documentation that time available of whether there was apparently no intracranial hemorrhage and carotid disease, so we could believe it to be a thromboembolic stroke that time. Thereafter, she did well for the next 9 years, and in 2018, she had a clinical event which looked like an acute coronary syndrome, in which she was tackled at an outside hospital and diagnosed to have a distal LAD disease, and that time there was some indications as well that she was having atrial arrhythmias with heart block. Her angiogram that time, I don't have the angio that time, but thereafter, from February 2019, I started seeing her. And the first time I saw her in her clinic, she was having bradycardia with a junctional rhythm, huge LA, LV dysfunction had set in. She had moderate TR that time with pulmonary hypertension and had a non-collapsing dilated inferior vena cava. Incidentally, in that hospitalization, she had a VTVF with a cardiac arrest and was revived out of that. And thereafter, when we did her angiogram, we found that her coronaries were actually normal, further strengthening our belief that the events which had taken place a year earlier in 2018 were more of an embolic event in the LAD rather than a primary atherosclerotic disease. So going by her history, what had ensued, we decided to do a RF ablation modification of the AV node, and thereafter we implanted a combo device, CRT-D, and following which the patient showed a good echocardiographic clinical recovery and continued to do well for the next few months. About a year later, in February 2020, she developed severe tricuspid regurgitation, which was preceded by episodes of atrial tachycardia, which were seen on her OPD visits and were treated both with amiodarone and flecainide. However, a month or two later, she developed signs of RV dysfunction. In April, about a month later, she developed RV dysfunction, which was then attributed, and there was a decline in the performance of her left ventricle as well. And for the first time since the implantation of the valve in 1998, we found that she had a prosthetic heart valve clot, which was treated with intravenous streptokinase infusion for 12 hours. That recovered, she did well. However, next month, she developed issues in her coronary sinus lead of her CRT-D device, and then that had to be programmed to a higher voltage to regain her LV capture. The next 6 months again were uneventful. She continued to do well with preserved ejection fraction, but in January of 2021, that means beginning this year, she had a septic shock, which was attributed to urosepsis, leading to with an acute kidney injury, which was medically managed. She came out of this whole medical problems over the next 4 to 6 weeks. However, by this time, her LV ejection fraction had fallen to 37%. She had developed RV dysfunction with severe TR. She had 1 or 2 episodes of spontaneous VT, which were treated with device shock. She had a good amount of hepatorenal dysfunction during this time, in which her bilirubin and the liver enzymes had really shot up quite high. And so was the degree of azotemia. However, she made a recovery. She staged a recovery on medical management out of this. And in February, she had kind of, after about 4 weeks of this illness, she had regained her normal renal parameters. The hepatic dysfunction was persisting to a certain extent, but by and large, it had resolved. We still did an angio this time, just to be sure that there was no progression or there was no new onset of coronary disease, which was normal. So this was our ventricular performance in January this year, where we find that there is a compromised, though very preserved thickness of the ventricular septal and the posterior wall thicknesses are well preserved, but there was some systolic dysfunction. The valve continued to do well. The mitral valve, the Star Edwards at the with the mean gradient of about 5 and a peak gradient of 11. The RV did show some degree of dysfunction with a severe tricuspid regurgitation, which the valves primarily looked okay. So it was a combination of both a tricuspid annular dilatation as well as the ICD lead, which was actually probably responsible also for the tricuspid regurgitation. The pulmonary pressures with a dilated IVC, which really was not collapsing, a TAPC of 1.3, a tissue velocity of the tricuspid valve of less than 10 centimeter per second made us believe that yes, RV dysfunction had also set in by then. We could demonstrate a caval reflux in the hepatic vein Doppler. Both the IVC and the hepatic vein Dopplers showed that there was a retrograde flow into the system. And this made us believe, going by her the multiple comorbidities, frailties, which were there in this patient, that a kind of intervention to treat this tricuspid regurgitation of a surgical nature may be very, very high risk. So then we decided to go in for the TricValve. As already been elucidated, a TricValve of the SVC has a long skirt to prevent PVL, unlike in the IVC where the skirt is much shorter. The pericardial valves on both sides on the inferior end of the SVC valve and on the superior end of the IVC valves are so designed. So we did a venous CT study of the heart in both the sagittal, coronal and the axial planes. The assessments of the SVC and IVC were done. The SVC looked reasonably straightforward with good landing zones on either side. And the SVC, the IVC, of course, also was okay in terms of the diameters which were there, but there was an angulation between the SVC and the RA junction. So there was a kind of a kink there, which we thought we could handle once we actually position and cross and take the stiff wire across from the IVC into the SVC. So these are the dimensions of the SVC from 1.9 at various diameters at the confluence, at the level of the pulmonary artery, and then at the SVC-RA junction. Then, and so were the diameters assessed of the IVC. And we decided to go ahead with implanting a 25 valve for the SVC and a 35 for the IVC. So the first step we did was that we positioned the multi-purpose catheter into the right pulmonary artery. This patient already had a central line in from her left jugular system. So we withdrew that central line a bit slightly proximal into the brachiocephalic. And then we also positioned a multi-purpose in the hepatic vein, did an angio to just have an idea of what the landing zones and what the distance from the hepatic vein to the IVC RA junction would be, which would help us in positioning the device. As you have heard that the SVC device should be as high as possible and the IVC device should be as low as possible. The idea is to stay away from the RA as far as possible. So this is what we first tracked the SVC valve into the vena cava. And as I said, if you look here, at this point, we withdrew the central line from the left internal jugular vein slightly proximally so that we could keep it free out of the way of the valve implantation. Now here are two distinct landmarks. This is obviously the brachiocephalic SVC junction, and this is the main pulmonary artery, the right pulmonary artery, across which you find that the undeployed SVC valve is being positioned. Now, as you know that the SVC valve has three prominent places, the crown, the belly, and the lower skirt. Important is to realize that when you are positioning the SVC valve, you should try that the belly of the valve, this catheter, the multi-purpose catheter just comes below the belly of this valve. So we started with the deployment step 1, keeping these landmarks in mind that when the valve is being deployed, the belly as it opens, as you see in step 2, it should just be superior to the pulmonary catheter in the right pulmonary artery, the multi-purpose catheter. Because all this and the other idea was to ensure that since the SVC valve has a long skirt to prevent a paravalvular leak, the idea should be to try to preserve the brachiocephalic vein and not obstruct it. So remember, the paravalvular, the skirt extends right across till here. And therefore, it's important that your brachiocephalic vein remains preserved here. So on the top end of this belly would be the brachiocephalic, on the lower end of this would be, at the lower end would be the catheter which is crossing the main pulmonary artery. So once you ensure this much, that these would be your position, remember at this stage also you can retrieve it. Dr. Katharina mentioned that up to 80% of deployment is possible, and you can keep adjusting the positions very, very patiently, very, very slowly. So therefore, I have tried to show it in multiple steps. So the same thing as you now see, the brachiocephalic cannula is coming at the junction of the crown and the belly, and the belly is kind of with the lower skirt is trying to make a indentation at the junction where the multi-purpose catheter is crossing the device. So this we are just at the threshold of now completing the deployment. And on the right side, you will just see as these, just about the skirt opens up. And the device is now fully deployed in the SVC. And this is where I was telling you, now you see the relationship of the crown, the belly, and the skirt. So where you find that how the catheters, the landmark in this brachiocephalic vein, in the main pulmonary artery, right pulmonary artery crossing the device, you see how the device has been positioned in the SVC just at the entry into the RA, and the valves are, and the SVC valve is right here, and the skirt goes right along the entire length of this. So then the assembly was retrieved, and now the next step was then to keeping the wire in position. We then went ahead with positioning the IVC. Now the IVC device, remember, has to be as low as possible, unlike the SVC, which has to be as high as possible. So the check angio again after positioning the device helps. You also had the advantage of landmark of the leads which were there going from the RA into the RV, and that further helped you. And this was all fluoroscopic guided. We didn't really resort to a T to counter check all this because the landmarks were quite well defined. So we had the landmark of the hepatic vein and we had the landmark of the leads, both the coronary sinus and the ICD lead, which were in the RA. And as you open up the device, you will see very clearly and must look for this sign. This is almost like what I call the champagne glass sign. As the device opens up, it looks like a champagne glass. And that actually tells you that the device has positioned itself quite well in the funnel of the IVC RA junction. And then you also have the advantage of looking at the of the landmarks of the two leads, the CS and the ICD leads, which serve as a landmark that you are probably in the right position. But still, you would obviously like to do a deployment angio as you are deploying the device and you're opening it up. You just do the IVC angio from the hepatic vein and just be clear that as you see the flow of contrast going from the IVC into the RA and you see no reflux coming back, you know by and large that your valve positioning well above you see this junction quite well, and this is where we find that the IVC valve is positioned right in this skirt, well above this. So this is that clear zone, and this clear zone should actually be just at the point where the IVC catheter is entering the hepatic veins. This ensures that your hepatic veins remain unblocked and they flow freely into the IVC device. So then it was a full deployment. Once we had taken that angio, we were clear, and that's how we fully deployed the device into the IVC. And the post-deployment venogram showed that the device was pretty much stable, well into the IVC RA junction, and it was neither too high nor too low into the inferior vena cava. And you could see the good flow of contrast from the hepatic veins going into the IVC RA without any reflux back. So thereafter, the hepatic vein catheter was removed. The device stability was confirmed in both the superior vena cava and the inferior vena cava. Both were well-positioned valves in situ. The patient showed, she stayed for about 12 days in the hospital, and just about on the 12th, 13th day, we did a chest x-ray to be sure that how her lungs and the pleural effusions which had accumulated were responding. And at 4 weeks, this was had almost cleared up. The ECG showed that her biventricular pacing, her LV capture were all restored. They were working fine. There was a normal tracking of the P wave. The rhythms were regular sinus. And at 4 weeks also, we had kept the lower rate programmed at a heart rate of 80, and we could get both the atrial and the ventricular capture seen very well. Her ventricular performance again staged a comeback. The LV functions improved. The mitral prosthetic valve continued to do well. Her INRs, remember, remained quite stable during this time, but for the time that when we had to do the TricValve, we had brought her INR down to about 2. And when we did the procedure, and otherwise we have always kept the INR between 2.5 and 3 in this particular individual. Her 4 weeks post-CAVI shows that echo shows fairly this. What you see here is a large IVC valve seen end on in the RA. The degree of tricuspid regurgitation by and large in this particular view looks like as if it's reduced. The pulmonary pressures are stable. The IVC flows are good. They are all unidirectional from the IVC into the RA. And overall, this patient has shown a good 6-week recovery post-procedure. She is home, she is ambulatory, she is kind of NYHA class 1, though for the 2 weeks that she was in the hospital, the heart failure showed a slow resolution, dominantly because that hypoproteinemia took some time to correct both by intravenous albumin and dietary resorts. She did have some problems of fungal urinary tract infection, which was treated before she was discharged. And currently, she is in good health, ambulatory, and continues to enjoy a good quality of life. Thank you very much.
Thank you, Dr. Puneet. An exciting case, a long journey for your patient. I think it's probably about 30 years and more. And this is what we expect from many of our rheumatic patients who have a valve issue at age 25, 30. And when they come up to an age of 70, they would probably need a few more procedures. So a combination of percutaneous procedure and a surgical procedure is probably the way to go when you want to harvest them for about 40 years from the first event. On that background, Dr. Puneet, your case is really exciting. It has probably shown all the features which we see in a rheumatic case presenting at age 20, 30, and going on for another 30, 40 years. So thank you indeed. Ravi, we move to next presentation.
Puneet, one question from my side. If suppose you have this obstruction of the hepatic vein or your pulmonary arteries, after implant releasing the valve, how do you tackle those things? You have kept a like a marker catheter in your
Pulmonary artery will not get obstructed because pulmonary artery catheter is only as a landmark.
okay.
Only as a landmark to understand how your lower skirt and the SVC would be positioned. See, the idea is to keep the SVC valve as high as possible. So there the pulmonary artery catheter serves as a landmark. You could end up even sometimes inadvertently occluding the brachiocephalic vein, though partially, but that doesn't create any issues. I am told, since it's my first case, that majority of the times, even if your device in the hepatic veins falls across it, majority of the times there is no clinical sequelae, since it's not just one hepatic vein which is all accounting for this. But certainly the idea is to prevent or at least ensure that some flow in the hepatic vein is seen. So it's not that your 100% hepatic vein ostium is uncovered. Part of the ostium of the hepatic vein would be covered with this skirt. And sometimes you have to be lucky with the anatomy as well. I understand that when you do a hepatic vein angio and you understand and you assess the distance from the hepatic vein to the IVC-RA junction, that in a way gives you a kind of a breathing space to see if you can go ahead with the device or not. And then you have these various device sizes of 31, 35 in the IVC, depending on what length you wish to implant, and you can have a choice with that. So I guess, I think with experience only we'll come to know more. First case, relatively uncomplicated anatomy. The challenge here was more not so with the anatomy, but with the overall clinical profile of this patient than with the anatomy. I guess she had a lot of challenges which she posed to us, including coming out from a very severe sepsis hepatorenal syndrome, where at one time the family was almost on the verge of leaving against medical advice, thinking that she'll not make it. So I guess keeping those things in mind, this procedure has had its share of gratification. Otherwise,
Thank you, Puneet. Dr. Anuj and Dr. Sharat Chandra, you have any comments on whatever has happened so far, or maybe the last case which Dr. Puneet presented?
Shirish, let's have the comments at the end. Would it not be good?
No, if you want to make any specific comment on the last case.
I would like to see the remaining presentations and then give my opinion.
Okay, we move on to next, Ravi.
Yes, sir. So we have Dr. Gomez Hospital, who is from Barcelona. He has got an immense experience of about 25 years in the interventional cardiology. He has membership with about a lot of national and international bodies, and he has been a reviewer of various international journals and is on scientific selection committee of various bodies. He has attended quite a large number of national international courses, seminars, and conferences, and he has contributed a lot of articles in index journals. He is skilled at various diagnostic procedures, support device procedures. He is skilled at all the aspects of PCI. He has been actively involved in the valvular therapies and then in structural heart therapies. So over to you, Dr. Gomez Hospital, and it's going to be a very exciting case which he would be sharing with us.
Okay, thank you very much. I want to share my slides. Okay. Okay, first of all, it's a pleasure for me to be here and to can share with you this different kind of patient that we are treated with a TricValve system. Probably with the presentation that performed Dr. Katharina Kiss, probably you will thought that in Spain the people are very special because there are no regular cases for tricuspid treatment. But it is another one that is quite different. I think it's interesting to present and to share with us. This is my conflict of interest. And we are move on to the case. What is the importance of the heart transplant and tricuspid regurgitation? The relevance is because tricuspid regurgitation is the most common valvular disease in a long-term survival patients after a heart transplantation. And the incidence of the prevalence of this tricuspid regurgitation can to be from 19 to 84% of the patients in a different degrees. And the relevance is that 6% of the patients will develop symptoms of right heart disease in the future. There are two mechanisms involved in the creation of this tricuspid regurgitation. First is the surgical technique that you are used for the heart transplant. The surgeons uses the bicaval surgery or biatrial surgery. When they use the biatrial sutures, the suture of the right atria produces a distortion at the level of the annulus that makes a tricuspid deformation that leads to a tricuspid regurgitation. The second mechanism is during the follow-up, in the regular control of the patient, you perform several endomyocardial biopsies that can direct damage to the valvular or the subvalvular apparatus. Our patient is 67 years old male. It is hypertension, diabetes, and hyperlipidemia as risk factors. There are several acute myocardial infarctions, and he developed an ischemic dilated cardiomyopathy, and they suffer in 1999 orthotopic heart transplantation. During the follow-up, a cardiac allograft vasculopathy was detected in IVOS controls in 2011. Our clinicians switch the treatment to Prograf and plus clopidogrel. There are other relevant history for this patient that the patient has a severe peripheral vasculopathy. In 2017, an extra-anatomic axillobifemoral bypass was performed. This makes some troubles in the procedure that we don't to treat the tricuspid regurgitation. And and also the patient has suffered a chronic anemia due to colonic angiodysplasia that was treated with laser and iron intravenous. In 2018, following an endomyocardial biopsy, the patient developed a severe tricuspid regurgitation. At this moment, medical treatment was started and the clinical stabilization was achieved with a combination of diuretics, digoxin, hydralazine, and nitrates. But in 2020, the patient developed a progressive severe cardiac failure with a right heart failure with persistence of severe tricuspid regurgitation. So at this point, we have to take a decision. This is not so all male, so we have to check for a solution of this problem. First was cardiac surgery, but there are commented previously, there's a high mortality rate for the patients treated for isolated tricuspid regurgitation. Even in a heart transplant patient, probably the mortality in hospital mortality can achieve 20%, 25%. So you have to search for another solution. That is a percutaneous approach. There's a lot of devices that you can use, but in our patient, we select the TricValve system with a BK system that put a valve in the superior vena cava and another in inferior vena cava, as mentioned in the previous presentations. So we perform a venous CT scan, and the measurements for the superior vena cava was 16 to 22 millimeters. So the valve that they are selected is a 25 valve for the superior vena cava. For the inferior vena cava, the sizes was at 31 millimeters valve. That was the measures for 31 millimeters in the transition from the right atrium to the inferior vena cava, or 31 and 92 in the top of the hepatic veins. So we decide to implant this TricValve system on our patient. There are some tips and tricks, some differences. We can see this is the angio performed during the procedure in the superior vena cava. You can see here there's a big dilatation of the superior vena cava previous to the entrance to the confluence in the right atrium. This is important dilatation. This is a big trunk, big right brachiocephalic trunk that can help to us to make the procedure. And is the pictal situated in the pulmonary artery. So at this point, you have to decide where to put the prosthesis. So this is the image that we have in the severe dilatation, and you can make an implant in a normal position of the valve, on the superior vena cava valve, that will be here in this position. Probably the belly is upper to the pulmonary artery catheter, so it is in place, but the risk is to have a very severe PVL. So in this case, we decide to implant in the higher position the superior vena cava valve to adapt to the dilatation of this valve to the anatomy of the patient and to avoid the paravalvular leak. So with this theory, this is the first position to try to make the implantation. But as you mentioned again before, this is the position in the higher position. It is the crown is close to the jugular vein, and it's a very big trunk that you have to avoid to make travel with the innominate vein, left innominate vein. So at this point, we start the procedure. This is a fast view of the procedure, because you are fast in the lab, but not so so this the upper crown, that the libre of the upper crown. This is the test that we are opening the belly. But it's important to make test because we didn't have any catheter in the innominate vein, in the innominate trunk. But you can see there is not obstruction of the innominate vein. So we follow with the procedure. We are opening the belly. It's quite a good expansion of the belly. And now we are opening the inferior part of the valve. It's located quite good. And it is adapted to the anatomy. We are making some tests to see the anatomy. So at this point, it is very, very slow deployment to be sure that it's not making any jump of the prosthesis. At this point, you make a test and you can see there is not obstruction of the innominated trunk. And this is absolutely adaptation with the dilatation that we have in the superior vena cava. After that, we start the deployment of the inferior vena cava prosthesis. And we have a pictal with the test and with the guidance that we follow the position of the inferior vena cava to avoid to jumping into the right atrium. We are making the delivery of the inferior vena cava system. The progressive, you have to make some an important tension to avoid the movement upper of the valve into the right atrium, and it's a quite stable delivery. You can see the final delivery. This is the moment. It is crucial to be quite slow, very slow, to avoid the jumping into the right atrium. And you have to test the position with the transesophageal echocardiogram and the fluoroscopy, and there is the implantation. This is the result after the implantation of the two prostheses. There is not regurgitation in the superior vena cava, and there is no regurgitation in the inferior vena cava. As you can see in the echo image, the valve in the inferior vena cava, the valve in the superior vena cava. And the most important is the hemodynamic result. You can see the pressure in red in the right atrium. This V wave from close to 30 millimeters of mercury, and is the inferior vena cava pressure that it's close to 10 to 12 millimeters. So there is an important gradient that is made by the valve and to preserve the circulation in the hepatic and the renal veins. So they was finished the procedure. The patient was discharged 3 days after the procedure. And just today, they fulfilled the 4 months after TricValve implantation. It was in the December 17. It's a good clinical evolution without heart failure signs or symptoms. He followed a regime of anticoagulation with direct anticoagulant with apixaban, and is making some episodes of anemia due to the angiodysplasia that the patient presented before, and periodic iron therapy was required. More interesting, 2 months after the TricValve implantation, we performed a CT scan. The injection was from the left cephalic vein. As you can see, the contrast arriving to the valve, and there is filling the right atrium, and there is no regurgitation to the inferior vena cava. There is no regurgitation to the superior vena cava. So the device works properly. This is another view of this injection. This dye arriving from the left brachiocephalic trunk. This the competition. The leaflets are okay and they're competent, and is absolutely competent in the inferior vena cava. Is filling the right atrium, the right ventricle, but there's not regurgitation to the inferior vena cava. So the conclusion for this case, the take home mentions that transplanted heart has a different anatomy than the normal heart. So TricValve system is a very interesting device in this kind of patients with atrial or cava sutures. In this particular case, a high implantation of the superior vena cava valve to adapt the anatomy was very important. The good cooptation with the anatomy makes no regurgitation, and the patient has a good hemodynamical profile and a good short-term clinical follow-up. Thank you very much for your attention.
Thank you, Dr. Gomez. That was really exciting. The entire case that you showed, and patient has undergone so much, and is being helped at every stage. There has been a problem.
Mm-hmm.
We go to next, Ravi.
Yes, sir. So next we have Dr. Manik Chopra, who hails from Ahmedabad, India. Sir works with Narayan Trudyalia as a structural heart intervention lead, and he is responsible for building up the structural heart disease program across the chain. So Dr. Chopra is one of the few formally trained structural heart disease intervention specialists in the country. So Dr. Chopra is also certified solo implanter for TAVR with all the 4 transcatheter valves that are available in Europe. Dr. Chopra has proctored more than 150 TAVR procedures across 12 countries for MyValve. And he has also done about proctorship of 30 cases in many countries in Europe, like Denmark, Italy, Spain, and on. Dr. Manik Chopra has proctored extremely challenging transcatheter mitral valve intervention cases. and valve-in-valve through transapical route at Croatia, and transcatheter mitral valve along with TAVR valve-in-valve at Kazakhstan. So it's quite interesting to have Dr. Manik Chopra share his experience on transcatheter valves versus surgical valves. Over to you, Dr. Manik Chopra.
Hi, good evening, friends. Sorry to join late. Thanks, Ravi, for this opportunity, and good evening to all my colleagues. I was given an option to probably discuss regarding the comparison between the surgery and the valve part, or to probably present some interesting case. So since the time is like 10-15 minutes and we are already running late, I would probably like to go with an interesting case which is related to the mitral position. And of course, we have dedicated TMVR system with PNF, which is soon going to come, as I heard. And maybe the only benefit of discussing this case would be to understand the transseptal approach, which would be probably common for the same system. So if I could be, I would try to share my screen if yes, I can.
You can share the screen, sir.
Let me just. Okay, so I hope you can see my screen.
Yes, it's visible.
Right. Okay, so okay, so this is so this is regarding TMVR valve in a patient with thick postoperative intraatrial septum, and these are my disclosures. This is about a 64-year-old male post CMV, 1995 post MVR biprosthetic valve pericarbon mod 27, which was done in 2004, which incidentally worked well up to almost 2020. And the patient presented with dyspnea on exertion, CCS class 2, which increased to class 3. Yeah, and regarding the blood investigations, there were no abnormalities. ECG was showing atrial fibrillation with fast ventricular rate, left atrial enlargement. Echo showed LA, RA, RV enlargement. LV was normal in size, biprosthetic valve at mitral position, MDG of 22 millimeters of mercury, severe eccentric MR, no PVL, mild TR, PSP of 55, normal LV and RV systolic function. TE, there was no LA or LA appendage clot. Interatrial septum was thick, and these findings were consistent on, whatever was there on echo was also there on TEE. Coronary angiogram was normal. CT analysis, we double checked that there was no LA appendage or LA main body clot. Interatrial septum was again very thick, and we were anticipating that probably crossing would be slightly difficult. The ID of biprosthetic valve was 22.8, and it had a suitable aortomitral angle with neo-LVOT of around 382, which was good. And these are the images which measure the inner ID of the biprosthetic valve, the aortomitral angle. And yeah, so this is regarding the reconstruction with neo-LVOT. And the strategy was like we did a heart team discussion, transseptal TMVR, valve in valve, general anesthesia with TEE, 26 millimeter balloon expandable THV with was planned, and we took the help of the app, valve in valve app. And the idea was that patient was very high risk for surgery because 2 surgeries were already done, and we had to look for an option. And we also saw that probably the biprosthetic valve was doing very well in such a patient in which the valve was first done like some 15 years back. So we expected the other valve also to behave in the same way. And we preferred a hybrid cath lab, but routinely we do not have such setups. So we went with a general one with surgical backup. It was general anesthesia with TE, and standard was to do a timeout with all the involved parties. And so this was regarding the septal puncture. Of course, you can see that this is an RAO view, and you can see that we have a pigtail which is parked, which curls down, and you can see that the needle is pointing slightly posteriorly in relation to the pigtail. But then we tried to do it again, and this is slightly more posterior. Of course, our puncture was more of echo guided puncture, and then once we were happy with the position of the site to puncture, we went with the the needle. But you can see that the needle is not able to cross. I mean, it is the septum was so thick that the BRK0 and BRK1 needle were not able to cross it. So finally, we took a soft end of BMW wire, which didn't work. We went to the hard end of BMW wire and tried to push it slightly in so that the needle could slide in, but finally it was not able. Then what we did was we just parked the BMW wire in the left lower femoral, in the left lower pulmonary vein, and you can see that we took the dilator off the SL1 sheath, and then we took a coronary balloon to dilate the septum because it was not taking anything else. This was 5/12 coronary balloon, and you can also see the waist. And once this was done, we tried to push the sheath in the LA with the balloon support, and the patient was fully hypnotised at that point of time, and LA pressures and waveforms were noted and recorded. Safari wire was then parked into left atria, and then we took a Gillish deflectable sheath, and you can see that the way the sheath is behaving, you can easily see that the puncture is good. It is inferior posterior, as we routinely would expect. And we have tried to align the valve in the RAO view, and it is more of RAO caudal, if I understand it correctly. And then we tried to pass the wire. It was just a straight, a pre-shaped, it was just a J-tip regular wire, and you can see as it is pointing so well, it tried to cross easily. Maybe you can take other wires if you're not able to cross with this, but it is very unusual if your puncture is good. We took an MPA diagnostic catheter, parked into the LV apex, exchanged it finally to a pigtail using an exchange length wire. LV pressures were noted, and then finally, we tried to push the Safari wire. At that point of time in India, we didn't have Safari wire. Somehow I got one sample, so we tried it, but this was Safari small. And actually the LV cavity was very, very small for this patient, and it needed a Safari extra small wire. So you could see that as soon as we try to pass the Safari wire, it doesn't sit in the LV apex at all, and the loop was actually too large for it, and it throws everything out. So finally what we did was Confida. Definitely the loop is almost similar to the Safari small, so we then took two excessive Emplatz wires because we were anticipating some challenge, and then we then did a balloon dilatation straight away with a 14 millimeter balloon, because the septum and as such was thick. You can see the waist, and then of course the other wire was behaving as a cutting wire. And then once this was done, we tried to dilate the mitral bioprosthetic valve, and then finally we took a 14 millimeter balloon and were trying to floss the septum. And you can see that it was not easy to cross the septum. We could try it, but with a lot of resistance. So then we again repeated the balloon dilatation. We waited for 1 or 2 minutes, and then again tried to use a THV to cross, but finally we could not cross with this. And then so then we also lost wire position in this, so we readjusted the wire with the help of a Gillish sheath again. And then you can see that we repeated the balloon dilatation with two 14 millimeters balloon by 40 balloon, creating a large rent in the septum. And then we were able to actually floss the balloon also, and finally we were able to place the valve across the previous bioprosthetic valve. And once it was done, it was again inflated with 2 cc's extra, so that you have a funnel shape and your valve is not being thrown back. It is almost like 90-10. It is funnel shaped, and it was a good position. There was no PVL, no gradients, And in this case, the tricuspid regurgitation, though it was severe, post-procedure, since the LV condition was treated, the TR decreased, the pulmonary pressures decreased, and even the ASD shunt was finally very small. It all collapsed to 6 millimeter or 7 millimeter. So as such, it was a good result, and it's almost like 1 year now, and the patient is doing well. So the only learnings in this would be, I would say that probably for PNF, with the coming of TMVR, transseptal way, probably this was how we could go transseptal way. And then, yeah, of course, tricuspid regurgitations, if you are able to treat the primary etiology, there is a fair amount of chance that it would decrease. Thanks a lot. Thanks for the opportunity to present this. So I can stop sharing, and thanks. Thank you for listening out.
Thank you, Dr. Chopra. I think in last hour or so, we are seeing more and more complex cases. I think tricuspid valve is probably like a very ancient car. People concentrate on the mitral, people concentrate on the aortic, and tricuspid is something which is also done simultaneously, but nobody ever focuses too much on this. So in all these cases, we have seen why tricuspid valve was so importantly handled for the better health of the patient. Thank you, Dr. Chopra. Dr. Ravi, we go to next. I hope all of you are staying for question answers.
We are done with all the speakers. So sir, now we can open the house for discussion.
Yes, so we have Dr. Sharat Chandra as well as
Dr. Anuj.
Yeah, correct. So, Dr. Sharat, any comments on whatever has happened so far, or you want to ask any questions to anybody?
Yeah, this is a very interesting session, in my first opinion. Wonderful cases shown, especially the last case. And, given the aging population of India, I think we are going to have a big number of patients who will be undergoing TricValve. You have a whole lot of patients who have severe tricuspid regurgitation from a variety of conditions. My question to Dr. Katharina is, what is the effect of this on the right atrial size and right atrial function in the long term? Because you have cut off the leak into the SVC and IVC by this TricValve, but per se the tricuspid regurgitation is not affected. So does it make the patient more prone for atrial fibrillation if it is not already there? Does the RA increase in its size, and so on? And the second question is,
Sharat, let's hear the answer and then we'll come back.
All right.
But at the same time, I mean, I would also like you to sort of compare if a valve in the tricuspid position is replaced and the way we have replaced a valve in the SVC IVC.
Yeah.
What is the difference?
Okay, so very good, very important questions, both of them actually. Maybe I address your question first, Dr. Harmath, because I think it leads to question number 2. So we know that surgical results are really not good because we simply close the tricuspid valve, thus often let the patient go into cardiogenic shock. The patient needs inotropic support, and we know that mortality is extremely high within the first 48 hours. By the concept of placing 2 valves in the superior and inferior vena cava, we first use the right atrium as a kind of reservoir. So in the first moment, in case of volume overload, the right atrium will balance this overload and the patient will not go into cardiogenic shock. We have, in all the cases we have done, and we have implanted TricValves now in by far more than 100 patients, we had very few cases with inotropic support. So this shows that the concept is right. For the right atrial and right ventricular pressures, of course, we ventricularized the right atrium. So in the first moment, the pressures in the right atrium will rise. What we have seen now in the 3 and 6 month data of our clinical trials in the CT analysis as well as in the echo analysis is that obviously by the changes in hemodynamic that we implement, it leads to a remodeling of the right ventricle. So what we see in the majority of the patients is that the right ventricle gets smaller. The right atrium that does not necessarily change, but of course, due to hemodynamic changes and less volume overload, also here the size might reduce, but I think more pronounced is the change in the right ventricle. So, and this is really important because of course, this was a concern in the beginning, what will happen. And we know now after patients entering the 2-year follow-up in the first early feasibility study, that we have no concerns about the right atrium and right ventricular function. And this is very important.
Okay. Hiramat, can I ask her the second question?
Yes, please.
What exactly is the significance of putting the catheter in the right pulmonary artery? Does it mean that it is the junction of RA to SVC?
Yeah, what we have seen is it's a good landmark because we use, of course, you want to use little contrast because most of those patients do have renal insufficiency. So you want to reduce the use of contrast. So it's very good to use your CT in an overlay technique. And for the SVC implantation, you do not need echo. So for this, we simply rely on an angiography that we are doing upfront and landmarks. And here the most easy to place is a catheter that just crosses the superior vena cava in the pulmonary artery. So this just gives you the level where you don't want to be below. So you always want to place the major part of your belly above this catheter. It's a very simple landmark, but it is very, very useful. This is it.
So the actual valve is just below the belly?
No, the actual valve is I can show you here, and I hope this is visible. So if you look at the inferior vena cava valve, you have the crown here, as it was mentioned. Then you have the skirt, and here the lower part, this part is the valve bearing segment.
Okay.
So if you have your pulmonary artery, the catheter in the pulmonary artery, you want it to be approximately in this position. You do not want the valve to be lower because then you have a risk that the landing zone is already tapering towards the right atrium. So this very simple catheter gives you the possibility of placing your valve, the belly of the valve, the majority of the belly should be above this catheter. So it's just a very simple landmark to help you during implantation. And I really want to congratulate both Dr. Puneet and also Dr. Gomez to their excellent cases because they really showed how to do it. And I think this is very, very, very well shown. And the important thing about this procedure is that you have time. You have time to consider your landmarks, you have time to position your valve, and the slower you do the procedure, the better. And that's why it's so important. Also, I think you marked that the case done in India by Dr. Puneet Verma was done without TEE. So you can do the cases in sedation. You do not need transesophageal echo. Echo is a nice to have. And of course, in those very difficult patients, like our heart transplant patients from Dr. Gomez, it's of course, you want to have all the safety you can get. But otherwise, in a patient with a good anatomy, that has a good window for echo for the right atrium, you can even go for transthoracic echo.
There is no marker for the valve. I mean, it's a fixed distance between the top end to the valve, valve position.
Yes.
But there is no marker indicating where is the valve, is it?
No, you see it very clearly. If you see it in the fluoroscopy, and I think you could appreciate this during the cases, you can see very clearly where the skirt starts, and you can see the skirt. So you know that in this part, you have the skirt, and this is the valve bearing segment. But it does not change anything for your strategy, because this makes always sure that you have no paravalvular leakage. So this does the sealing for the valve. So as long as you anchor the valve properly in the superior vena cava, whether this protrudes more or less towards the right atrium will not change the function of the valve segment. This is very important. You're absolutely right.
How much of the lower end of the valve should be protruding into the right atrium?
As little as possible, but it depends very much on the anatomy. As we have seen in Spain, we were treating patients which were rather petite from their size. So obviously also the length of the superior vena cava was shorter. So that means, of course, sometimes you cannot avoid that the valve protrudes a little bit into the right atrium. Ideally, you want as much of the valve inside the superior vena cava as you can do. And this is also why we were pointing out that the strategy of implanting the valve really high, even into the jugular vein or into the anonymous vein, is important and is a very good option. And the same is true for the inferior vena cava. This is the part that is most stable, the part where you have the skirt and the valve. So it is very important. Ideally, you have your diaphragm here, so it protrudes minimally into the right atrium, because this will give the valve a maximum stability, and you will feel it while deploying the valve. If this is positioned correctly, then the valve will sit quite still and will not dance or move. So then you know you're in a good position.
You're not
I was going to
concerned
ask you why it must have so much length, the skirt below the valve level. But I think you already explained that.
For the superior or for the inferior?
No, for superior.
Yeah, but because you have to see that the belly, the skirt covers the maximum diameter of the belly. So if you imagine you have your vessel wall here, you will still want to cover this part in order to prevent paravalvular leakage. And this is why in this case, the skirt is really high. Whereas of course here, you want to prevent blockage of the intrahepatic veins. So you want to have a short skirt. Here there's an open cell design. And anyway, in those patients, hepatic veins are huge. And all of the patients are on oral anticoagulation. And I think this is also very important. If we looked at all our patients that we have done so far, all of them were previous to the procedure already anticoagulated, because either they had mechanical prothesis or they had the atrial fibrillation.
Isn't there any concern about blocking the left innominate vein if you put this as high as possible?
That's a very good question. This is why we do an angio in that case, trying to visualize the inflow. But this is also why here you have an open part and an open cell design. So this will normally allow without any problem. So until now, we didn't see any cases where we abstracted the anonymous vein.
Okay, thank you.
Anuj Kapadia, you have any inputs on whatever happened so far?
Excuse me, I'm Dr. Gomez-Hospital. May I have a question for Dr. Katharina? There are several patients that we are studying for tricuspid regurgitation, but there are patent foramen valve or small, very small interatrial septum defect. What is your opinion on this case? These cases, because there is changes on the hemodynamics on the right atrium. You can make a change like an Eisenmenger with the shunt right to left in the following months. What your opinion?
Very important question, because although if you do transeptal and you treat the mitral valve first, of course you might end up with mini ASD. So we recommend to close it with a device before you do the tricuspid valve. And probably it is good to treat the mitral valve first, then give it a 4 weeks time to see. But in doubt, I would close it, because exactly as you said, we change the pressures and this might lead to a kind of Eisenmenger reaction. So it's good to change.
Okay, thank you.
Very good question. Excellent case, by the way. I really love it.
Thank you. Thank you very much.
Any questions, comments from the faculty?
Manik, isn't this extreme dilatation of intraatrial septum, did it lead to a left-right shunt at the end of the procedure in your case? You used a 14 mm balloon dilatation of intraatrial septum. Okay, I think he is not there.
The cage, the length of the cage is, how much is the length? It's about 30 centimeters or maybe more?
65, I guess, to be precise, 65, 67 of the SVC and IVC.
Sorry?
It's about, the SVC cage comes in two sizes, 25 and 29 has a length of about 66 and 69.
Can you be a little bit louder? I think we can't hear you too well.
The SVC valve, they come in two sizes, 66 and 69 millimeters long, whereas the IVC valve are constant at 65.
All right.
So that's the entire length of the, and that's the length post deployment.
Dr. Hiremath, I have one question. Dr. Katharina, you must be knowing all the outcomes of the entire world experience. What were the complications you encountered in these patients?
So I'm very happy to say that this is a very safe technology. So first of all, we had no in hospital and on the table, so within 48 hours mortality. The main complications that we saw is bleeding at the puncture site. This is really what we saw in several patients. We had in the early feasibility trial, we had one valve migration due to low placement. Of course, there we also had a learning curve that we had to achieve. In the CE trial, we had one valve that migrated a bit towards the right atrium, but is stable there, which we also decided together with the physician that it should have been implanted higher. Otherwise, we had no need for new pacemaker. There was one patient with a pacemaker, the same where the valve migrated a bit, where the pacemaker had to be replaced. But otherwise, it's a very, very safe procedure. So you had no signs of heart block. You had no, of course, this is the safe part about it because you don't intervene with the tricuspid valve itself. So you do not intervene with the His bundle, you do not intervene with the coronary arteries. There is no mingling with any of the cardiac structures, which makes it a very safe technology. And it's also important that it's straightforward and you know that normally it will take you less than 1 hour from the beginning of the procedure to the finalization of the implantation. And I think this is also important because our patients are really sick and we do want to treat them in a proper way.
How do you compare the two-valve implantation versus single tricuspid valve implantation?
Surgical.
Well, I think, sorry.
Go ahead. Please go ahead.
Okay, I think as I said, first of all, the tricuspid valve is a very, very complex structure. It's huge once it's dilated. We have the anatomy of the cusps of the leaflets. We have the proximity to the structures. And we have the problem if we close the valve at once, then the patient might not tolerate this. I think all of us have already seen the dimension of the tricuspid annulus in progressed disease. And I think we have touched the annulus and see how soft the tissue has become and how difficult it might be to anchor a structure in this kind of annulus. So until we do not find a really convincing solution, this is much safer and much easier. And still, we do not have this problem of volume overload that we might cause by single valve implantation into the tricuspid position. If you ask me about single valve implantation in the cavas, as it has been done with the Sapiens valve, well, we had a case in India where we only implanted an inferior vena cava valve. The patient after that showed signs of volume overload in the upper part. So we had the jugular congestion, headaches. We implanted a second valve through the inferior vena cava valve, and only after the SVC valve had been implanted, the patient improved. So we strongly believe, or I strongly believe, in the concept of two valves, because otherwise you just shift your problem.
In India, rheumatic fever was very common in early days. There are many patients you would find where you have left-sided valves are replaced, mitral and aortic, and tricuspid, they put an annulus ring and they sort of tighten it. Many times the left-sided valves continue to function well. However, the tricuspid regurg is gradually progressive. So in these cases where there is a ring in the tricuspid position, which one would you prefer, the two valves in the SVC-IVC position, or since you already have an annular ring, a single valve in actual tricuspid position?
Look, I still think that it will be much easier and straightforward to place the two valves in the cavas. But of course, in this very special situation, this is of course different, because then it's like a valve-in-valve procedure. Then you, of course, can consider this, but also there, I mean, it might not be tight enough or small enough for a balloon expandable valve to go in this. And from the tricuspid valves that are emerging, because none of them is really there, I think we will have to see how this can be positioned if there is an annulus already in place. Yeah. So I think this will be a question for the next years, but at the moment, the safest device to place, in my opinion, is the B-cover valve, so the TricValve.
So who hit upon this idea first time, this TricValve? Because it's completely novel. And
it's completely novel. So we developed it together with the University of Jena. And we took over the concept, we developed it, we did the design, everything. So it took a long time. It's almost 10 years now that we've been working on the concept.
Okay. Congratulations for bringing such an interesting and almost mind-blowing idea.
Thank you very much.
Very good talk and very good presentations, all of you.
Thank you, very kind.
Many times the surgeons, they actually shrink the tricuspid annulus. I mean, surgery for the tricuspid regurg would involve sort of putting in a ring and make the ring shrink and leave the valve leaflets as they are. So on that background, something like that has been previously done. And can we put this kind of two valves in SVC and IVC and expect a good functionality?
I think if I understood you right, I mean, we have the annuloplasty devices such as the cardioband.
Yes.
But again, these procedures, I mean, in Europe, they're not so often performed because it takes quite a long time. The result, as I showed with the one case, you have like the cardioband failure that I showed. I think that due to the soft tissue where you are putting screws into it, it might be difficult to reach a satisfying result. So you want a technology that is very straightforward. Of course, I mean, this is one of the big advantages of the TricValve technology. If you place your IVC valve almost level with the right atrium, you can still go through the valve and go do an annuloplasty, go transeptal, do whatever you want, which I think is a big advantage because we're in the beginning of a long journey. So if we treat a patient now, we don't want to prevent any future treatments. So even if you feel, okay, maybe I can reach more by doing an annuloplasty in combination, you can still do that if you're not satisfied with the result.
Are there any more points or questions for discussion?
I think, sir, there is one question in the chat box. Dr. Nagesh has put this up. I believe a part of the question has been answered. What happens to RDI anatomy and pressures after successful CABI deployment on follow-up? So his question is, on follow-up, what happens? How does this manifest?
But
Dr. Katharina?
yes, as far as I understand, I mean, we have discussed the question, we have addressed it. So I might repeat it. We can see that after 3 to 6 months, we can see a complete remodeling of the right ventricle with a decrease of volume, which is very important. And in the consequence, pressures will drop. So, but this is a hemodynamic procedure. So this is due to the hemodynamic changes. This is not, you will have, of course, an immediate drop of pressures after the implantation below the IVC valve and above the SVC valve. This you can see in a very pronounced way. This is very good to control your valve function. What you can follow up on echo is that you have the hepatic vein inflow is completely null, so it will not be there anymore. This is very good to control. The reverse backflow is completely null, so this is very good to control your valve function. And otherwise, as I said, the right atrium does not take any harm. It's ventricularized, this is correct, but what we saw from the long-term results, there is no issue with that.
What about RV dysfunction? I mean, is there a set limit below which you don't do or above which you do?
Yeah, I think this has been very nicely shown in the first talk in this chart, where you can see that there is a point of no return and that we should not go below this. And I think if right ventricular function is too impaired, then we might have crossed this point of no return. So that means we still recommend to have slightly to medium impaired right ventricular function. TAPSI is sometimes difficult to interpret if the patient had prior annuloplasty, for example, because then the TAPSI will not reflect right ventricular function. But at the moment, we are still trying to stay with patients with mildly to medium impaired right ventricular function. If the right ventricle is severely impaired, then I think we have crossed the point of no return. Very good question. Yeah.
So the assessment based on MRI for RV function, are there any set criteria where we say yes and where we say no?
Look, MRI, we have tried to include MRI in our clinical trial, but of course, due to the fact that many of the patients had pacemakers and prosthetic valves and also renal impairment, this was difficult to do. I mean, I did my MRI studies in London. I was with Dudley Pinnell at the Royal Brompton, so I'm very familiar with cardiac MRI, my favorite technology when it comes to imaging. But I would say, I mean, a cutoff value is very difficult to say. I think we are too early in the technology. This is why I'm trying to be a little bit vague on it, saying, okay, moderately impaired. I think as long as we, and this is also when we try to reflect in the V wave, when we do the right heart catheter, we try to also measure the V wave, which is called, of course, is very dependent on the diuretic status or on the diuretic status of the patient. But we would like to make sure that there is a backflow into the cavas, so that with this backflow, we can assure valve functioning. And this is why the right heart catheter is a crucial part of the screening procedure. So we first want a CT scan to assess the anatomy. If the anatomy is suitable, we go for the right heart catheter as a second important pillar of the screening process. Yeah.
What about the super elderly, 80 plus, who have slow progressive tricuspid regurg? Peer pressures are, say, mid-50s, and you can see the TR is progressive. So you think these would be good candidates for this kind of repair?
Look, here I think we're still in a learning process because we have learned that we treat patients too late. I think this is something that we all are aware of. In a patient 80 plus, I would of course take the symptoms into consideration. Because of course for a person 80 plus, being on daily high dose diuretics is also something that decreases the quality of life. So if we can help those patients because of their peripheral edema, because of ascites, because of this, by valve implantation, if the patient is mobile and still has an acceptable quality of life, I think this is also a reason, or this is a good indication for valve implantation. And we have seen this. We have done patients, for example, in Brazil with Chagas disease, who have suffered extremely. Those are young patients, they are in their 40s, but they have a massive edema, massive peripheral edema, massive ascites. And after TricValve implantation, we could really help them a lot. They were free of symptoms and their quality of life improved dramatically. So I think this is also always the weighing, also in a patient 80 plus. I mean, there are patients that are really still have a good quality of life, besides the fact that they suffer from right heart failure. And I think these patients can, of course, be addressed.
Thank you.
Thank you very much.
I think
Are there
you
any
can call it
questions
off.
or?
Yeah. So there are a couple of questions, but I believe these have been already answered during the course of discussion or during the course of presentations. So I think with that we are done. If there are no other questions, may I request my colleague, Mr. Kennedy Fernandez, to give vote of thanks.
Well, on behalf of Relisys Medical Devices, I take this opportunity to thank all of you, our chairperson, Dr. M.S. Hiremat, for guiding us through this meeting, our moderators, Dr. Sarat Chandra, Dr. Anush Kapadia, our speakers and presenters, Dr. K Hazra, Dr. Katharina Kiss, Dr. Puneet Verma, Dr. J.A. Gomez, and Dr. Manik Chopra, and all you delegates and attendees. Thank you for being part of this initiative of Relisys Medical Devices. We look forward to interacting with you in the near future again. Thank you and good night.
Thank you so much.
Thank you for bringing
Thank you
all
so
of
much.
us together. Thank you.
Thank
It
you,
was a very
sir.
exciting webinar. Thank you very much.
Thank you very
Thank you.
much.
Thank you so much.
Fantastic.
Bye.
Everyone. Thank you all. It was wonderful.
Thank you very much from Germany.
Bye.
Thank you.
Thank you, everyone. Bye-bye.
Thank you, everyone.